Thank you, Dr. Thanaraj.
All right, good evening, everybody. Thanks for joining us tonight. We have a great program for you today about COVID in children, back to school issues, and an update on COVID vaccine in kids. So just a couple of housekeeping things. All lines will be muted during the program. There is a question and answer, a Q&A box just on your panel down below. Please go ahead and leave any questions there or any comments. Questions will be answered after each of the presentations. This evening is brought to you by the California Immunization Coalition, which is a statewide nonprofit dedicated to ensuring that all Californians have access to life-saving vaccines, as well as by the American Academy of Pediatrics. Next, Cameron. There we go, which is a partnership of all 4 California AAP chapters. The AAP is committed to attainment of optimal, physical, mental, and social health and well-being for all infants, children, adolescents, and young adults living in California. So Eric, Dr. Eric Ball and I will be your hosts for tonight. I am at Children's Hospital Los Angeles, and he is from Children's Orange County Primary Care Network. So I'm going to throw it to Eric to introduce our first speaker.
Thanks, Pia. I have the privilege of introducing my colleague, Dr. Jasjit Singh, to give our first presentation on children and COVID. So I'm not going to read her whole bio to you, but she is a pediatrics infectious disease subspecialist at Children's Hospital of Orange County. She's assistant director of the Division of Infectious Diseases and is the medical epidemiologist for the hospital. She did her undergrad at Harvard, and most importantly, she got her medical degree at Duke University. On a personal note, I want to also say that Dr. Singh has really led the effort of our hospital and our community against COVID-19, and all of us in Orange County turned to her for her expertise during the last 14 months or so, and I feel like we could not have gotten through this pandemic without her. She has a tremendous amount of wisdom, and I'm super excited that she's agreed to come and share that with all of us today. So the privilege of introducing Dr. Singh. Thanks for joining us.
Thank you, Eric. That was very kind. Thank you, Pia. I'm really happy to be here today. And since we want to cover a lot of ground this evening, I'm going to jump right in. So next slide, please, Cameron. Thank you. So I'm going to be talking about the recent epidemiologic and clinical experience of COVID and Misc in pediatric patients. Then we'll talk about why pediatric vaccination is important, and go into some of the successful operational strategies that schools have used. Next slide. So throughout this experience, the CHA and AAP have really given us a lot of valuable data, particularly for pediatrics. So this is the epidemiologic curve of our whole pandemic. And you can see the adult cases in light blue and the child cases in dark blue throughout this time period. And you can also see on the left-hand side that at the beginning, the pediatric cases made up 2 to 3% of the total. And as time went on, that proportion started to increase. And now, poor audio, I'm seeing in the chat. So I'm going to try to get closer to my microphone. I hope that's better. As we went further along through the pandemic, that proportion increased. And you can see that most recently, the pediatric cases comprise 19% of the total cases. So, and in the last couple of weeks, that number was as high as 24%. So that's probably due to a number of different reasons. First of all, more and more adults have gotten vaccinated, so children are making up more of the total. But also we are testing more mildly or asymptomatic cases. So I want you to keep those numbers in mind as we move forward in our discussion. Next slide. All right. So in the text here, we have the AAP data, and that is through May 20th, so very recently. And you can see on the right that we've had a total of almost 4 million pediatric COVID cases with a case rate of more than 5,200 per 100,000 population. And if you like to see things visually, as I often do, and you look at the graph there to the left, this is CDC data through January. And you can see how the um, pediatric cases compare to incidents in older age groups. So you can see that they're significantly lower. And you can also see that in that young adult age cohort, there's a pretty high incidence, which I think we've all learned. In terms of hospitalizations, as of last week, there have been approximately 15,000 hospitalizations of pediatric patients. And we also know that children represent about 2% of the total hospitalizations. And if you look at it the other way, if a child gets COVID-19, the chance that they will be hospitalized is about 0.8%. Looking at mortality, there have been about 300 deaths. So children are representing about 0.06% of all COVID-19 deaths. And conversely, if a child gets COVID, the chance of mortality is 1%. So if you want to see that visually on the graph from the CDC through the end of January, you can see that mortality in children, fortunately, is super low compared to the older population, particularly that first line, which is 85-plus-year-olds. Next slide. So this is our entire CHOC experience with COVID in our whole enterprise. So there's a lot of granular data here, but I'm just going to point out some of the highlights. So if you look at that right-hand corner there of the big table, you can see that in our enterprise, we've had about 5,000 COVID positive patients. If you look at those first three columns, you can see that fortunately, most of those have been outpatient. But we have had over 500 kids who've needed to be hospitalized, of whom about 100, so close to 20%, have ended up in the ICU. Now, the caveat to that is that not all of that 500 were hospitalized for COVID. Some of those were hospitalized with COVID. And there's a recent paper out of Stanford that suggests actually that at least in their population, about 45% of the hospitalized kids were there with COVID. So that doesn't, of course, answer the question that they ask in the paper, and we've all asked, whether some of the kids that we saw this last winter, say with appendicitis or DKA, whether those kids actually were triggered, those conditions were triggered by the COVID that they had or not. So there's a little bit of a gray area there, but that's our number here, about 500 hospitalizations and 76 Misc patients. Next slide. So what happens when we've had to hospitalize these kids? Well, just briefly, most of them, fortunately, have been outpatient and have just gotten supportive care like they would with any other viral infection. Some of our high-risk kids, we did give convalescent plasma to, particularly at the beginning, under a research protocol where we looked at the safety and kinetics. And we recently published that, and the citation is there to the right. We also, if they met criteria of being over the age of 12 and greater than 40 kilos and were in a high-risk group, we gave them monoclonal antibodies. If they were sick with COVID, then we gave them remdesivir and or dexamethasone, depending on where in their disease course they were. Very rarely did we give one of the IL-6 or JAK inhibitors. So most of the kids were managed in that fashion. Next slide. I do want to spend a few minutes, though, on Misc, because I think that this part of the story is unique to a pediatric facility and really isn't accounted for if we look at just our acute COVID numbers. It really doesn't reflect the entire burden of disease in a children's hospital. So the Misc definition, if you'll remember from the CDC, is a hospitalized individual under 21 years of age with fever and 2 or more organ systems involved and significant evidence of inflammation by CRP, ferritin IL-6, all of those kinds of measures, and evidence of SARS-CoV-2 infection. These kids were very, very sick. Many of them were in shock. And the difficulty for us was how much overlap there was between other more common clinical entities, and that made their care just much more complex. Next slide. The CDC, as of May 3rd, is enumerating 3,742 patients meeting that case definition. And there is a backlog, of course, with this. And they're also citing 35 deaths so far. In this data, they also mention that 2/3 of these patients have required ICU care. Next slide. This is a really nice graph, I think, of our own CHOC experience, where you can see that the COVID cases are in blue, and you can see when those waves were. And then about 4 weeks later, you see our Misc patients and those waves in red. And so this makes sense because we know that Misc is in fact a post-infectious complication. It was really interesting while we were taking care of these kids to find out that symptoms were really mild that had several weeks earlier, or maybe they were completely asymptomatic. But boy, when they came in with the Misc, they were really, really ill. Next slide. Here's a map from the CDC and just showing you that California wins the prize for the most Misc cases in the country. Next slide. And looking at the demographics on the first graph, you can see that minorities were overrepresented in terms of our Misc patients, as they were for our COVID-19 patients. In the pie graph, you can see that Misc patients, there were more males than females. And on the bottom, you can see that age groups, really school-aged kids is what we saw the most of, from 5 to 14 years. Next slide. As far as treating these kids, well, I have to say at the beginning, we all thought that it was going to be like treating a Kawasaki's disease patient. There is some overlap in the clinical features. So we thought we'd give them some IVIG and they'd feel better in the morning the way our Kawasaki's kids often do. But these kids really did not respond in the same way. They were much sicker. They had a lot of third spacing and shock type issues. So we found, as did others in this particular study, that in addition to IVIG, they really did need the steroids. And we ended up giving all of them both. And I have to say that, you know, as a clinician who's been doing this for a long time, it was really very anxiety producing for all of us to be sort of feeling like we're building the plane as we fly it, because this was a completely new clinical entity for all of us. Next slide. So we get to the question then about why we need to vaccinate kids. And so, you know, I think that hopefully I've been able to show you that the incidence, hospitalization, and mortality is lower in pediatrics, but certainly not zero. And it hasn't been a completely benign experience. So we have the kids with acute disease, the Misc kids. We have the long-term complications from both of those entities. And we also have kids that are showing up with post-acute sequelae of COVID, PASC, or otherwise known as long haulers. And of course, the kids can still spread disease to others in their family or in their community. Kids under the age of 18 represent 22% of the population. So we do need to think about them when we're thinking about achieving herd immunity. And we want to avoid pockets in which the virus can continue to replicate, because that's when it will mutate and create variants. We know that by allowing parents to return to work, we can help open up the economy. But I think most importantly, we have all seen how kids have suffered during this pandemic. Just their education, physically, mentally, emotionally, they need to get back to school. So next slide. Returning to school. This is a really cute CDC infographic that I like. It's got all kinds of really nice little hidden messages throughout. Next slide. So let's talk about getting back to school. So the CDC School Guidance talks about 5 key prevention strategies: the consistent and correct use of masks, physical distancing, hand washing and respiratory etiquette, cleaning and ventilation, contact tracing with isolation and quarantine. And so, what the guidance recommends is layering 2 or more prevention strategies together, with particular emphasis on using masks and physical distancing. Next slide. So, what do we know so far about schools and SARS-CoV-2 transmission? Well, based on the available data, in-person learning in schools has not been associated with substantial community transmission, which means basically that school outbreaks have not seemed to lead to community outbreaks, which is great. Evidence suggests that staff-to-staff transmission is more common than transmission from students to staff to students, or students to students. And that's been shown in some studies from the UK and Australia, and especially true for younger children. And I have to say, from doing infection prevention at our own hospital, this has certainly been our experience that we've had more trouble with exposures in our cafeterias and lounges than we actually have had from patient exposures. So this has been affectionately dubbed break room breakouts, and I think that it's really a real thing. So when you combine those those prevention strategies and adhere to them, the risk of transmission in the school setting appears to be lower than or equivalent to transmission risk in other community settings. And that's been shown in international and local studies. Next slide. What about physical distancing and this whole issue of 6 feet, which we use in the hospital, versus 3 feet? Well, there have been several studies from Europe that have reported low levels of transmission when they use 1 meter between students and schools. And of course, you remember that 1 meter is just a little over 3 feet. The preponderance of the available evidence from US schools indicates that even when students were placed less than 6 feet apart in classrooms, there was limited transmission as long as other prevention strategies were consistently maintained. And those do have to be maintained at 6 feet when masks are off, for instance, while eating or between adults in the school. So I think altogether, we can say that consistent with recommendations from the WHO and the AAP, a distance of 3 feet between students seems to provide good protection as long as it's layered with the other prevention measures and those are adhered to. Next slide. So the CDC Operational Strategy for K through 12 schools was just updated on May 15th. And on the right here, you can see their tiered outline. So in this operational strategy, they suggest that evidence shows that many K through 12 schools that have been strict about implementing prevention strategies have been able to safely open for in-person instruction and remain open. All schools should implement those prevention strategies and prioritize universal and correct use of masks and physical distancing, as we discussed, regardless of vaccination status. And the CDC has maintained this stance for the end, for this few weeks, for the end of the school year, and are expected to have new updates out by the fall. Testing can certainly add to that. We'll talk about that. But most importantly, we know that vaccination for teachers and staff provide great additional layers of protection in our schools. Next slide. So besides the importance of school, we know that so many of our kids' lives center around their sports activities. So here on the right, we have the Orange County return to sports tier system. And you can see as reported here that on February 23rd, Orange County went into the orange tier and was allowed to resume football. And more recently, Orange County actually has entered the yellow tier and so is able to resume indoor contact sports. Next slide. So a couple of other issues. I think ventilation has been a big issue throughout. So this is a study that's fairly hot off the press that was just released by the CDC on May 21st. And this study looked at Georgia elementary schools K through 5 in the fall of 2020, so before vaccination. And what they found was that COVID-19 incidence decreased by 37% in those schools where teachers and staff were required to use masks. So you may ask, well, what about the students masking? Well, about half the schools did that. And in those schools, there was a 21% drop, and that was not felt to be statistically significant, but probably added to the entire decrease. They also, though, looked at ventilation and found that there was a 39% decrease in incidence with improvements in ventilation that they broke into two categories. The most important, which was dilution method, as they call it, which is basically a very fancy way of saying opening the doors and windows and turning the fans on. So with those dilution methods, a 39% drop, and that's certainly easy to do with our great weather here in California. That can be augmented with filtration methods, such as HEPA filters in those places where maybe it's difficult to open doors or windows. Next slide. And then finally, the question of testing in schools. This also hot off the press on May 21st. So this is a study in Utah high schools from November 30th to March 20th. And this study was actually done during a period of high COVID incidence in the community. And the school district implemented two testing programs. The first was for extracurricular activities, a test to play sort of strategy, where they did antigen testing every 2 weeks. And with this strategy, they were actually able to complete 95% of their competition and allow it to proceed. Then they also had a test to stay type plan, where basically schools that reached a certain threshold of transmission were given the option to either go to all virtual learning or participate in this test to stay strategy. And with that, they were able actually to save a huge number of in-person instruction days. So altogether, if you read this report, they did test 60,000 students with a positive rate of testing of 3.2%, so fairly low. So next slide. We now have data really to suggest how schools can safely open in the fall. But all of this is augmented, of course, by our ability now to vaccinate at least some of our kids, hopefully more as we go on. And so now Dr. Sawyer is going to review the data for the Pfizer vaccine in 12 to 15-year-olds and tell us what the future holds for us.
Dr. Singh, that was awesome. Thank you so much for the recap of what we've been going through with COVID-19 in children for the past 14 months. We have just a few minutes for some questions, and then we'll move on to Dr. Sawyer. A common question that we received, and you touched on a little, is what do you think the school environment is going to be in the fall? And I know you don't have a crystal ball, but I think we can imagine that middle and high school kids will all have had the opportunity to be fully vaccinated by then, and hopefully the majority of them will be. We assume that most teachers should be vaccinated. The little kids probably will not. Do you see high schoolers still wearing masks? Do you still see elementary schools doing the same things they're doing this year? What do you think is going to happen in August and September?
Yeah, well, you know, my crystal ball has been a little bit foggy throughout this whole thing, but I'm trying to polish it off. So the CDC has promised that they are going to be updating their guidance. So I'm hoping that that will help us. You know, I think that it's going to be hard to know exactly how many of our kids are vaccinated. That's going to be one of the challenges. And that's the challenge, I think, as we talk about this in all our settings right now, right? So I think that that's going to be difficult. There may be teachers and staff with high-risk conditions. That's another thing to keep in mind. So I think that I think in most of the indoor classroom settings, I suspect that there still will be some masking. And certainly for the younger kids who have not been vaccinated yet, that may be the case as well. So looking forward to seeing how many of our kids actually do get vaccinated and what the CDC thinks, the best course of action is for those people, because that's really an important question for us, I think.
Thank you. On the topic of masking, can you give advice on how to keep children safe and healthy now that the mask mandate will be lifted for those who are vaccinated, even outside of schools, knowing that children will not be immunized yet?
Yeah, I think that's a question on most parents' minds. And I think that really parents are going to have to tackle this a bit individually based on their circumstances. So, first of all, is the child high risk? That may change the equation considerably. Secondly, is there a high risk individual in the household that the child might transmit to? And then what kind of activity is it? Honestly, I really think that the vast majority of outdoor activities for kids are pretty safe. I really do. The risk of transmission in the outdoor setting is extremely low. And so I think for the average kid who's running around playing outside, they're pretty safe. If they're in a more crowded outdoor space, say, a sports event or something else where people are really crowded together, that might be different. And of course, indoor spaces are in general very different. So for indoor places where they're a private setting, you may know who's vaccinated. I think that risk is significantly lower. If you're in a public place, though, and masking is no longer required, we don't know who's vaccinated and who's not, I think that it's probably safer to keep your kid vaccinated. And maybe if you don't have to take them with you, don't take them. So I think it is going to be individualized. And in my mind, there's a big difference between indoor and outdoor activities and transmission.
So one more quick question, and then we'll turn this over to Dr. Sawyer. So question from one of our participants: are there any differences in transmission rates of COVID among high school students versus elementary school students with a 3-foot distance? So does age matter?
So age does seem to matter a little bit. So the high school students definitely seem to act more like adults than the younger children. And so when we talked about those school transmission studies and the fact that most of the transmission was between staff members, less from student to staff or student to student, that transmission risk did go up as you got to older and older age cohorts. So yes, there is some difference. In general, as I said, in the schools, even with those high school students, it was less than what was in the community, but definitely higher than in the younger elementary school age kids.
Thank you very much, Dr. Singh. I have the pleasure of introducing Dr. Mark Sawyer. Dr. Sawyer is a professor of pediatrics and infectious disease specialist at UCSD and Rady Children's Hospital in San Diego. He's also the program director of the residency program and the medical director of the UCSD San Diego Immunization Partnership. He previously served on the advisory committee for immunization practices and was called back to serve on the FDA advisory committee to review COVID-19 vaccines. On a personal note, Dr. Sawyer was my very first ID attending when I was a medical student, and I wanted to be him when I grew up. So I'm very honored to be introducing him tonight.
Thank you very much, Pia. Let me just see if I can share my screen effectively. I hope you're seeing the title slide. So my job tonight was to update everybody on COVID vaccines in children. And in many ways, this is the easier job of the two of us because we mostly have unanswered questions about COVID vaccine in children. And so I will speculate when I can in response to your questions, but I too have lots of questions about COVID vaccines in children. In fact, here are my questions. Do children really need COVID vaccines? Do COVID vaccines work in children? Are COVID vaccines safe? Obviously, the question of the week is myocarditis, and is that a real association with mRNA vaccines? I think we don't know that yet, but it's certainly had a lot of media attention. How are we going to get all these kids immunized? We're having a big enough challenge getting the routine immunizations in. Now we have to add COVID vaccines, and 2 doses of them in most cases. What about MIS-C? Dr. Singh gave you a nice overview of MIS-C. The last thing we need is a vaccine that causes MIS-C. And since we don't completely understand the immune response that gets triggered and leads to MIS-C, I think this is a very important question. And then, as I've already mentioned, what are we going to do with all the other vaccines, and the question about co-administration of COVID vaccines with our routine vaccines. So I'm going to go through these pretty quickly because, again, we don't have lots of answers. So the first, do children need COVID vaccines? I think Dr. Singh already did a good job of explaining the rationale for immunizing children. I know that this is a question that comes up because of the low mortality in children and the relatively low morbidity. But when you add it all up, it's not trivial. As Dr. Singh pointed out, there so far have been at least as many deaths in children in the United States from COVID as we see each year with influenza. And we find that an important motivator to get kids protected against influenza. And of course, we have all the other reasons that she mentioned about transmission and generation of mutant variant strains if we continue to allow kids to spread infection. And although the overall story on schools is positive with regard to not contributing a lot to the community outbreak, here's one study that showed parents of kids who were in full-time in-person school had more COVID than parents of kids who were only in part-time. So full-time versus part-time school, correlating with the degree of exposure in school. You'll notice the risk is higher in older age groups, which has already been covered. And of course, we don't know exactly how well these schools were practicing the guidance of ventilation and social distancing and masking. But I think we can all accept the general concept that kids probably do transmit to their family members when they get infection, the way we see with many other respiratory viruses. All right, how well do COVID vaccines work? We only have a single clinical trial that's been publicly released at this point. To answer that question, it was a phase 2/3 trial done by Pfizer. And as you well know, the FDA issued an emergency use authorization, which is short of full authorization, but allows the vaccine to be used. This is a 2-dose vaccine. The dose and the interval between doses was exactly the same as it was in the adult trials. So nothing is really different about the approach down to age 12. The participants in this study will be followed for up to 2 years. So we will learn about long-term side effects, at least in this small cohort over time. But so far, the results have been good, and I'll share the safety data shortly. This is the demographics of those studied compared to the older cohort, 16 to 25-year-olds that were already studied and led to the use of this vaccine down to age 16 for several months now. As you can see, this is not quite as diverse a population as was included in the adult studies. We only have 4.6% Black or African American, 0.3% Native Hawaiian or Pacific Islanders. Hispanic population's only 11%. So one criticism of this study is it's not completely representative of the US population. And that message has been sent by CDC and the American Academy of Pediatrics to the manufacturer in the hopes that the subsequent trials in younger kids will hopefully have a more diverse population. Here are the antibody levels. So this was a so-called bridging neutralizing antibody comparison study, which means we're comparing the level of antibody that 12 to 15-year-olds get to the level that the older kids get for whom we already know that the vaccine works. And the 12 to 15-year-olds are on the left in blue, the older group in the right, and the two subpanels within each side, the darker bars are the immunized participants compared to the placebo participants. And as you can see, the level of antibody achieved in the younger group is higher than we. This is not really to be expected. We see that with HPV vaccine, for example, a better immune response in younger adolescents than in older adolescents. So by this measure, the vaccine works great. This wasn't the intent of the study, but they actually had enough COVID disease to show that there was a clinical effectiveness as well. As shown in this slide, looking at actual incidence of COVID infection, there were 0 cases in the vaccinated group and 16 in the placebo. So that's a statistically significant difference, which basically suggests that the Pfizer mRNA vaccine is going to work just as well in young adolescents as it does in older adolescents and young adults. And that's what we know so far in terms of effectiveness. And we will learn more over time. And as many have probably heard, the Moderna vaccine, they released their preliminary results to the media, like their outcomes were the same, similar. And they haven't yet submitted to FDA, but I expect they will very soon. And so we should have a second mRNA vaccine to give to younger adolescents relatively soon. I think what's concerning us and parents the most are side effects, whether we can be comfortable to give these vaccines in adolescent and younger child populations, given that their burden of disease is lower, their mortality is lower. This, by the way, is a picture of what an FDA advisory committee looks like. It's not all that glamorous, but the FDA does a very thorough job of reviewing safety. And I can assure you that they are really concentrating on the pediatric studies to answer the question that we all have about the safety in this younger population. Here are some local side effect data after dose 1 and dose 2. Again, the left-hand bar in each set is the vaccine group, the right-hand bar is placebo. As you can see, the vaccine behaves very similarly in young adolescents as it does in older adolescents. Sore arms, redness and swelling, and particularly pain at the injection site in a significant number. The more important systemic side effects are shown here. This is just with dose 1. In this case, the vaccinated group is on the top line, the placebo is in the bottom line. And children do get fevers, they do get fatigue, they do get headache, there's some chills, just like we see with adults. And with the second dose, this slide shows the same information, but for dose number 2. Again, fatigue, headache, fever, muscle pain, joint pain. I'm going to scroll back and forth between the two slides for a second. This is dose 1. This is dose 2. Dose 1, dose 2. So just as in adults and older adolescents, side effects seem to occur more frequently with dose number 2. And so we for sure need to advise our patients of that and have them plan to get vaccinated when they don't necessarily have to be fully functioning the next day. This is straight from the ACIP meeting on May the 12th, during which the CDC recommended use of vaccination down to age 12. They pointed out that there were no cases of anaphylaxis. If you remember several months ago, we were all worried about anaphylaxis as a side effect of these vaccines. There was no Bell's palsy or facial paralysis. There were no thrombotic events. That was the safety concern of several weeks ago. And of course, this week we have concerns about myocarditis. There were no myocarditis cases reported in the study, but again, the sample size is quite small. And as with all of these rare side effects, when you start to immunize millions of people, it is inevitable that we're going to see rare side effects. And the question is showing for sure that they're causally linked. And if they are, deciding whether the risk of that side effect outweighs the benefit of getting vaccinated. So given all that uncertainty, what do we know about whether parents are going to get their kids immunized? And then where are we going to do that? Here's a study also presented at the ACIP meeting looking at parent intent for getting vaccination. Somewhere between 50 and 70% of parents had at least likely, but you will notice that there are racial and ethnic disparities just as in the adult population. So we have our work to do to educate and convince families to get immunized so that everybody in the family is protected, and as a society we're protected against the circulation of these variant strains. I think everybody realizes it's a big challenge to get kids immunized, particularly in the adolescent age group. Although the primary care provider is the best option, it isn't always going to be feasible for kids to go to their primary care physician. Primary care physicians are gearing up as we speak to deliver these vaccines, but I think we need to take advantage of other sites, pharmacies, for example, and in places that have the ability, school-based vaccination is certainly a good option that has worked for many other vaccines when it can be done. The issue of consent is, of course, different in adolescents than it does in adults. The federal government has no requirements for consent, but states do. And in California, a minor cannot consent on their own for a vaccine, for this particular vaccine. To some extent, these laws may vary by county, so I would recommend you check in with your local health department on consent issues. I think there was a question sent in before the seminar tonight about consent in unaccompanied minors, and that's definitely going to be a challenge. So hopefully systems can be set up to get kids to get immunized, and there maybe have to be some special exceptions for unaccompanied minors that we're dealing with, particularly at the border setting. Dr. Singh already covered MIS-C, but this is obviously a huge question for the vaccine rollout. Is there any signal that these vaccines trigger MIS-C? So far, the answer is no. So in the Pfizer clinical trial and the use of vaccine to date, in the general population, there have been no reports suggesting MIS-C, and we've now given enough vaccine to younger adolescents and young adults that we're beginning to see the rare side effects, hence the myocarditis story. So at the moment, I'm reassured about MIS-C, but I think as we move into the younger population, we're going to have to be really careful to make sure that we have adequate information to assure safety before we start using the vaccine routinely. This doesn't come up often, but the question was addressed at the ACIP meeting. What do you do with somebody who's already had MIS-C? Do you take a chance on immunizing them? As is the general recommendation for people who've already been infected with COVID, they're still recommended to get vaccine. But what if they got MIS-C when they had COVID? And the CDC gave some criteria listed here for which you might still consider vaccinating, depending on risk factors and the types of issues that Dr. Singh brought up about their risk status from getting COVID a second time and family contacts who may be at high risk from COVID. And lastly, I want to talk about all the rest of the vaccines. So we are way behind on routine vaccination. This is data discussed at the ACIP meeting just for adolescents. You know, we're 11 million doses behind in 2021 compared to 2019. Tdap, HPV, meningococcal rates are all down 15 to 20%. Same is true in California for younger child vaccinations. Didn't show that data here, but we have not yet dug out of the hole that was created for us this past spring a year ago when kids were not coming into their primary care office and not getting their routine vaccinations. So it is important that we get to work on that as we consider giving COVID vaccines. And fortunately, there is a new update from ACIP that will make that easier. That is an acknowledgement that co-administration of COVID vaccines with other routine vaccines is now considered a reasonable option. At first, the recommendation was to have a 14-day interval between COVID vaccine and any other vaccine. That has now been removed as of the May 12th ACIP meeting, and it's based on now significant experience with COVID vaccines. We have given over 250 million mRNA vaccines in the United States. And inevitably, some of those were given close together or even simultaneously with other vaccines, and no serious side effects have been identified. So this is the actual statement. COVID-19 and other vaccines may now be administered without regard to timing with other vaccines. And the AAP, just to put an exclamation point on it, issued a statement which was published in Pediatrics a few weeks ago, basically saying the same thing. So it's okay to get kids caught up on their routine immunizations at the same time you start to deliver COVID vaccines. So overall, I think the major concerns are in the side effect profile of these vaccines, particularly as we go to younger kids, specifically the triggering of MIS-C, and additional studies looking at co-administration to make sure that we don't cause an unexpected safety concern by doubling up COVID vaccines with others. Here's where we are with the younger age group. Both Pfizer and Moderna have already started clinical trials. In the case of Pfizer, I believe they're down to age 5. In the case of Moderna, maybe all the way down to 6 months. Both companies eventually intend to evaluate their vaccines all the way down to 6 months of age. So we will have data. Pfizer has stated publicly that they're hoping to submit their data on younger kids, the first cohort, maybe down to age 5 by September. But as was discussed earlier, kids are not going to be immunized when school starts. They may start to get immunized right around the beginning of school, but it's of course going to take time. The dose may be different in kids. That's one of the points of the clinical studies, is to find out if the dose needs to be adjusted. Of course, side effects are high on everybody's mind. So that's a quick summary of where we are with vaccines. I'm happy to open this up to discussion and comment.
Thank you very much for that. Some of the questions that have come up by attendees several times are the association of COVID vaccine and myocarditis, as you mentioned, fertility and menstruation. Those seems to be coming up over and over again. Can you comment on how to counsel parents or teens about that?
Yeah, unfortunately, we don't have the fine print yet on the myocarditis story. It is being carefully evaluated by CDC as we speak. I am on the Western State COVID vaccine safety group, and emails have been flying around that group all week about this story. What I can tell you is that it is being very carefully and rapidly evaluated. My sense is that it's going to probably be a real association, but it's going to be rare. It's going to be like the thrombotic events that are occurring in adults. And when the calculation gets done, the question is, as I said earlier, is the risk from the vaccine higher or lower than the risk of getting COVID in adolescents and certainly in younger adults, younger kids, because they have less burden of disease. So it's going to be a complicated equation. Stay tuned.
Thanks, Dr. Sawyer. Dr. Singh, you can chime in with these questions as well if you'd like. Question I had from some of the attendees was the need for booster vaccines. I know the data on that is slowly coming out. What are your thoughts?
You know, I think it's probable that we will need booster vaccines, but each report that comes out pushes the time for that further down. It was going to be 6 months, and now people are talking about duration of a year or longer. It, I think, will depend a lot on the variant strains that have started to emerge, and if those continue, it's not so much a booster as it might be an updated vaccine with new components in it, just like we do with influenza. We update the influenza vaccine to accommodate the mutations that occur naturally as influenza spreads. We may get in that same mode with COVID vaccines. Interestingly, I was listening to a webinar today where Walt Orenstein, who used to be the head of the CDC immunization program, predicted that we would need boosters, but he was not confident about when that was going to be. So I'll stick with his opinion.
Once the COVID vaccines are fully FDA approved, what is your feeling about if the vaccine should be required for school or for social or athletic events or for the workplace?
Yeah, that's an excellent question. And, you know, as people probably know, it is already being required by many universities for enrollment either now or certainly by this fall. And again, whether to push that down to secondary schools, middle schools, and even elementary schools is going to depend a lot on the safety profile and whether we're comfortable that we're not going to cause harm by immunizing the whole population in that way. So I think we need to wait until we get the safety data before we can really answer that question.
I'll just add, Pia, that there's an editorial by Dr. Plotkin in Pediatrics about just that topic, about mandatory vaccination for children. And in it, as you might guess, Dr. Plotkin is making the case for mandatory vaccination. So I thought it was really interesting and certainly from one of the giants in the field, in case anybody wants to take a look at that.
So at every AAP NCE National Conference and Exposition, Paul Offit gives the same talk every year. And his talk is, he pretends he is a nervous mother and asks questions about vaccinations. And it's the job of the audience members to be the reassuring pediatrician. So I'm going to play that role today, and I'm going to ask each of you guys a question. So Dr. Sawyer, I wanted to give my child the COVID vaccine, but she's only 13 years old. She hasn't even had any babies yet. How do I know she's not going to become infertile?
Yeah, well, the real answer is we don't have scientific evidence yet for the COVID vaccines about any impact on fertility, but we do know that it has been given to many, many adults now, to over 250 million, no reports of fertility issues. There is no vaccine that we give routinely that affects fertility, so I have no reason to think this vaccine is suddenly going to cause a problem. There's no biologic reason to think it's going to cause a problem. And in the meantime, her risk of getting COVID and having serious consequences, potentially even including infertility, is real.
And Dr. Singh, I'm very concerned about my child's DNA. I mean, she's only 14, and she has that DNA her whole life. Why would I alter it with this RNA vaccine?
I don't think we should alter her DNA, but I don't think that will happen from the vaccine. So the messenger RNA does not get to the cell nucleus. It's in the cytoplasm. It cannot get to the nucleus, and that's where your DNA lives. And that messenger RNA is going to be degraded very quickly, so there is no chance of your child's DNA being altered. And I just want to also chime in about that fertility piece, because, gosh, I am getting that question probably more than any other, even from our younger staff at the hospital. And in addition to the biologic implausibility that Mark mentioned, I think there's some social media out there stating that there's a placental protein, syncytin, that's has some homology to the spike protein, and somehow this is going to cause molecular mimicry. And this is a physician, I think, who's advocating this and using these technical words to convince people that this is a real scientific thing. And, that homology, first of all, is a very, very short segment that would not cause molecular mimicry. And I think I heard it best from one of my colleagues here, an OB colleague, who said, really look, if you and your best friend have the same, have phone numbers and they both have the number 7 in them, what is the chance that looking at your phone number, you're going to be able to guess your best friend's phone number? There just isn't. And I thought that was a really good analogy in terms of the amount of overlap and the likelihood that there would actually be a biologic problem.
I like that. Thank you.
So I guess just in the end, if you have a parent that's just hesitant, knows the data, isn't really concerned about fertility or any other things, but just says, I think we should wait and see what happens, wait for more data, wait to see what, happens with the vaccine down the road. How do you counsel them?
I mean, I would start with the seatbelt analogy. You don't wait to put your kid in a seatbelt, and because you realize that every trip you take is a risk. So leaving your child unvaccinated when they can be vaccinated, and we have good information that it's safe to be vaccinated, is taking a chance. And Dr. Singh pointed out, MIS-C happens in adolescence. Long haul COVID is something we're still unraveling, and that seems to have serious and potentially permanent consequences. And not to mention, you want your whole family to be safe. So leaving one of your kids unvaccinated is going to run the risk of introducing COVID into your house and causing more disease.
Yeah, I would agree with that. And I think the perception is that if we just wait, we're not taking a risk. So getting the vaccine is a risk, and just waiting to see what happens is not a risk. And so I think it's important to really explain to parents that there is that risk in just waiting, and that you're going to have to really weigh both of those risks. And when you do that, I think the balance comes out that you should get your kid vaccinated.
I mean, the other thing I guess I'll throw in, the CDC, the one good thing that's come out of the so-called anti-vaccine movement is the infrastructure to study vaccine safety is really much more robust than it ever was before. And there are now networks and systems that are going to detect rare side effects very quickly. We're seeing that already with the thrombotic events, the myocarditis story. We just started immunizing adolescents a few weeks ago, and we're already hearing about myocarditis. That never would have happened in the past. So if there's a side effect that's serious, we're going to learn about it.
I wanted to thank you, Dr. Sawyer, Dr. Singh, for joining us today. This was fantastic. Before we go, just a few housekeeping things. So first, Kate Williamson, who's the president of the AAP in Orange County, pointed out that all 3 AAP chapters in California that contribute to the AAP in California, Chapter 1, Chapter 3, and Chapter 4, all have really good resources for COVID on their websites, including fact sheets that you can hand out to your patients or your practices. So I encourage you to go to your local AAP chapter websites and get some of that information. Number 2 is you guys will get an evaluation at the end of the screen. The evaluations really help us to figure out what we're going to talk about next moving forward. This is our 6th COVID conversation. We've been doing this for the last 6 months, and we've had some great speakers, and really thankful to everyone who's joined us. We're probably going to take a month off going into the summer and maybe do this every other month until the fall. So stay tuned. We will be in touch when we have our next COVID conversation. Again, thanks to Dr. Sawyer, Dr. Singh, and for all of our participants. You can find all of our previous talks on our YouTube channel, which you can see below, or on our California Immunization Coalition website. So thank you all again. Have a great night, and we look forward to seeing you at our next talk.
Good night, everyone.